now we have reached the last section for the cardiovascular chapter in your first aid book. I actually believe it is the most important because 80% of the patients you will see in your clinical years and career will have been on some type of drug that will be covered in this cardiovascular pharmacology section. Antihypertensive therapy. Okay, here is the deal with the medications for hypertension. You need to know all of the mechanisms of action and side effects. If you understand the pathophysiology of a disease and the mechanism of action of a drug, you do not have to memorize when to use certain types of medications. Just think of it as preventing the further progression of the pathophysiology of the disease you're being asked about. So let's not waste any more time and get started with primary or essential hypertension. The exact pathophysiology of the disease is not completely understood or clear, but I like to think about it as an excess or unnecessary sodium retention by the kidneys due to inappropriate neurohormonal renal responses, particularly overactivation of the renin-angiotensin-aldosterone system, impaired excretion of sodium by the renal tubules can cause increased pressures due to retainment of water because water follows the sodium that is being retained, and expansion of the intravascular volume. So if sodium is really high because we are inappropriately retaining amounts of it and inappropriately excreting low amounts of it, it can actually enter the endothelial cells that are sitting in our vessels. So you have an increase in the intracellular sodium of endothelial cells and vascular smooth muscle cells. If you activate voltage-gated calcium channels because of this increase in intracellular sodium, you will also have an influx of calcium. And an influx of calcium into endothelial cells can cause endothelial cell dysfunction. And an influx of calcium into vascular smooth muscle cells will give you contraction. So again, it can enter endothelial cells and activate voltage-gated calcium channels, causing increased intracellular calcium, and it can also enter vascular smooth muscle cells, which we know leads to contraction. So if we actually have contraction of our vascular smooth muscle cells, if we remember this equation, blood pressure equals the total peripheral resistance times the cardiac output, we're increasing our total peripheral resistance due to this vascular smooth muscle cell induced contraction, and therefore we will have an increase in our blood pressure because we increase our total peripheral resistance. So you remember this equation, you know it by heart. This sets us up perfectly for understanding the therapeutic regimen for treating primary or essential hypertension. So you give diuretics such as hydrochlorothiazide, and this is to block the excess sodium that is within the tubules, and if you block the distal convoluted tubule sodium chloride transporter, the HCTZ or hydrochlorothiazide directly competes with the chloride component of the sodium chloride transporter on the distal convoluted tubule cells. You will have less sodium reabsorption. Also, we use angiotensin converting enzyme inhibitors. Or, if they are intolerant, you can use angiotensin receptor blockers, because this decreases the renal activation of the renin-angiotensin-aldosterone system and also the sympathetic nervous system that can also be activated by activating the renin-angiotensin-aldosterone system. And number 3, we target the intracellular calcium levels. That was the problem that can be induced by high levels of sodium opening voltage-gated calcium channels. So the third method of the therapeutic regimen is calcium channel blockers. So again, in quick review, primary essential hypertension is due to problems with retaining too much sodium, not secreting enough, overactivation of the renin-angiotensin-aldosterone system. We treat that with ways to block sodium reabsorption, such as hydrochlorothiazide, to block the overactivation of the RAS system with an ACE inhibitor or an ARB if they develop a cough from the ACE inhibitor. And we also block the effects of very high sodium levels on endothelial cells and potential subsequent increases in intracellular calcium in vascular smooth muscle cells and endothelial cells by giving someone a calcium channel blocker. Okay, so what is the difference in treatment between primary hypertension and hypertension with congestive heart failure? Well, the congestive heart failure either resulted from a diastolic or a systolic dysfunction. Either way, both of these eventually led to the activation of the renin-angiotensin-aldosterone system, the sympathetic nervous system, and also led to a component of endothelial cell dysfunction. So, you approach this attack with a similar mindset of preventing the sympathetic and angiotensin-induced vasoconstriction while also blocking the RAS system with ACE inhibitors and aldosterone antagonists, in addition to giving a diuretic to help eliminate some of the excess sodium that the body will be retaining in response to the activation of the renin-angiotensin-aldosterone system. So you block the RAS with aldo antagonist and also give ACE inhibitors. And again, you give ARBs if they are unable to tolerate the ACE inhibitors because they can develop cough and angioedema. And you give beta blockers to inhibit the activation of the sympathetic nervous system. What is important to know is that you can only give a beta blocker to a patient that has congestive heart failure with an adequate ejection fraction, because you do want to decrease the chronic beta adrenergic stimulation on the heart and the juxtaglomerular apparatus, but you cannot use this on patients with decompensated congestive heart failure or those in cardiogenic shock, because they terribly need that last bit of beta adrenergic stimulation to maintain whatever low cardiac output they might have. So again, let's quickly review whether they went from diastolic dysfunction or systolic dysfunction to congestive heart failure. There is an overactivation in response of the RAS system. There's also activation of the sympathetic nervous system, and there's a component of endothelial cell dysfunction. We can treat the activation of the RAS system with a ACE inhibitor or an angiotensin receptor blocker, and we can prevent the overactivation of the sympathetic nervous system with a beta blocker. You only use beta blockers in patients that have adequate ejection fractions because they are dependent on that last bit of beta adrenergic stimulation to maintain that contractility that they need because they have a decreased ejection fraction. So what about hypertension with diabetes mellitus? This is really important because so many patients have diabetes, but you can prevent the vasculopathic changes, particularly the renovascular damage to the efferent arteriole. So let's draw the afferent arteriole, and then this is the glomerular apparatus, and then this is the efferent arteriole. I remember this by the afferent goes at the glomerulus and the efferent goes exiting the glomerulus. So when you have a very high level of glucose circulating around the blood, you eventually start to accumulate sugars on the proteins sitting on the endothelial cell surface. So here is your vessel, and there are little proteins sitting on the endothelial cells everywhere. They are very active, dynamic cells. Eventually, you start putting sugars on the amino ends of these proteins that are on the surface of endothelial cells. Eventually, you accumulate very reactive advanced glycation end products. So you get non-enzymatic glycation because there's so much sugar here circulating around in the blood, it just binds to the amino group of proteins that are found on the cell surface of endothelial cells. This leads to the development of breakdown products associated with sugars sticking to these proteins, and we call these reactive advanced glycation end products, and these can cause oxidative damage to the endothelial cells of the renal arterioles due to the induction and production of free radical species such as superoxide and hydrogen peroxide. So we have increased oxidative stress. This combination of increased oxidative stress due to the production of superoxide and hydrogen peroxide and the release of vasoconstrictive substances such as endothelin-1 by damaged endothelial cells will result in severe vessel damage and vasoconstriction. So this gives us vasoconstriction of the efferent arteriole. So we need to give these patients something to inhibit even more vasoconstriction occurring at the level of the efferent arteriole. Remember, angiotensin II receptors are all over this efferent arteriole. We need to block the ability of angiotensin II to bind to these receptors. And we do that with an ACE inhibitor. This is good for patients because anytime that you prevent this vasoconstriction at the level of the efferent arteriole, you prevent an increase in the hydrostatic pressure within the actual glomerular capillaries. So just think about it this way. If your efferent arteriole is this size, and you cause the efferent arteriole to vasoconstrict to a very small diameter, you will increase the resistance here, and more pressure will be transmitted to the actual glomerular basement membrane, endothelial cells, and podocyte foot processes that actually compose the filtration barrier. And this chronic high pressure will take basically a pounding to the glomerular capillaries, and that is really bad because you are further causing more damage in combination with what our advanced N-glycation products were doing to the endothelial cells of our renal capillaries. So again, we give an ACE inhibitor to block the ability of the production and binding of angiotensin II to the efferent arteriole, and we also can give calcium channel blockers to relax some of the vascular smooth muscle that has been damaged and induced to vasoconstrict. So we can also give calcium channel blockers, and that helps further alleviate some of that vasoconstriction.